if I need to talk to you, so I need to get myself prepared.
We're under the impression that your portion is not going to be on Monday's exam. It's going to be on.
Nobody told me. Nobody told me. Anyway, so it's a 12 question. I don't know. I just don't know your. I didn't receive the syllabus or something. I asked Aaron my lecture schedule, whatever. So I don't want to say anything, but I'm well prepared. I see this type of patients very often in my own clinical practice. 12 questions for RSV, 12 questions for drug-induced pulmonary diseases. I never had this big portion of questions for my section for this, like this, but I will review it for you, okay, for those questions. So I will give you a review after this lecture. And pay attention. You can see those lecture slides. All those underlined, bolded, are the questions. Does it make sense? Okay? Because when I write a question, I go back to the PowerPoint, I underline those questions I give it to you. Okay? So pay attention to those underlined in your lecture slides. And let's start, okay? So RSV is a virus. So it's one of those respiratory viruses. You have all of us, you and me. We have many viruses colonized in our airway, okay? That won't make you sick, but if your immune system is weak, or say if you have 5 exams next week, you study so hard this week, you may get sick. That's just how it works. So this is one of the virus, pretty much make 100%, I would say. You actually get, already get infected in some point before 2 years old. In the first 2 years, you get exposed to this virus. But why it didn't make many people sick? Only those kids, only those newborn baby who don't have a mature immune system, or they don't have a mature lung. They were mature boy. How old the baby born considered mature? Do you know? 36 week gestational age. Okay? If they stay in their mom's belly for 36 weeks, then that's considered mature baby. Before that, it's considered premature. When I was did NICU rotation, the newborn baby, the NICU rotation, we see many newborn baby 23, 24 weeks. Their lung did not develop well, so they are very vulnerable for this type of virus infection. Okay. So this is a virus. I believe after the pandemic, all of you already know the virus structure, right? So it's mainly spread because you contact those respiratory droplets. Say the baby went to daycare, okay? So one of the other baby was sick with the RSV, then they sneezing. And then those droplets go to the surface or the toys. And the other baby try to touch those surface, and then put their mouth. What they like to do is this, right? So they get exposed to this virus. That's how it's spread. You can imagine. Of course, hygiene is the #1 priority. One thing you should do to prevent this type of infection. So they can survive many hours on those hard surfaces. So it's the hygiene. We'll talk about that. How to prevent it. For developed well. So those are the issues. It has some hospitalization for bronchitis or pneumonia. So it's actually not uncommon. So I will test you those epidemiology numbers for sure. So there are only one serotype. However, there are some, as you can see the virus, and on the surface there are many different proteins, right? Those are called antigen. Those antigen can cause people sick. So there are two major subtypes with A and B. That's why even you get RSV infected before, you still can get reinfection because the different A and B subgroup, okay? So how it make you sick? When the virus is same, it's actually same for all the virus. All the respiratory, majority of the respiratory virus has the same pathogenesis. When they affect the cell, they make the cell die. And then your epithelial cell don't have a regeneration very well. They cannot which organ has the best regeneration capacity? Anyone know? Liver. Why liver? Liver has very good regeneration. That's why you can do the live donor. Say, if my liver matches yours, I can donate it to you. It's not just those death donation. Because if I donate 1/3 of my liver will still regenerate some of the function and it won't affect my regular life. So, but your lung, your airway epithelial cell don't have that type of regeneration capacity. So they die, then they cause the further permanent dysfunction of the airway, the permanent dysfunction of the lung. So that's why the necrosis could be an issue, and those regeneration of those epithelial cells could be an issue, and then cause obstruction of the airway and cause further lung damage. That's how the virus causes their pathogenesis, and the risk factors you definitely need to know, because you need to recognize those high-risk infants. Who are high risk? Should we give them prevention? Should not? What should we do? So the risk factor is always during the RSV season, October through April, and usually the youngest newborn baby, the high risk. So what the parents need to do, or what the providers need to do, is educate the parents so they know the first 12 weeks of their newborn baby are the high risk. Okay? The youngest, the higher risk, because their lung and airway are not fully developed. Okay? So what you need to do is prevention as strict as you can to prevent them to get RSV exposure at the very early age. Okay? Once they pass those age, they won't become the high risk. Okay? So especially those premature or low birth weight infants, that could be life-threatening. Why? It's because if they are born before 29 week, remember 29-week gestational. If they before 29-week gestational means their lung is not fully developed. So they're so vulnerable for this type of infection. And also if they have chronic lung diseases, or especially those premature babies, because the lung wasn't developed fully in the gestational age, so they usually have chronic lung diseases. Okay, after born, their lung cannot develop well. And some of the baby has the cardiovascular defects, right? So those have cardiovascular or cardiopulmonary. Sometimes we say that because your heart and your lung are linked together. They're one system. If your heart has issue, it will affect the lung. If the lung has issue, it will affect your heart. That's how it works. When you go to the adult comorbidities, you will understand the daycare, their sibling, the older siblings should wash their hands when they come back to the home, come back from the daycare to home, or if they don't really routinely clean the surface in the house, or clean the toys, share the bottle, the siblings are share their drink bottle, right? So those are increased the contact spread of this virus. Okay, that's the other additional risk. If parents smoke, if the kids are cigarette exposure, also increase their risk. And any other hygienes, all those are increased the risk. So clinical presentations, pretty much you cannot tell what RSV infection compared to the others. All the virus infection are very similar with very minor differences. For RSV, I need you to know, besides the fever, besides the sneezing, the runny nose, sore throat, all those common cough, all those are the common signs and symptoms for the virus, like rhinovirus, adenovirus, parainfluenza virus, stay on the airway, those viruses are very similar signs and symptoms. But for RSV specifically, it has a lot of secretion and a lot of runny nose. Okay, so because of the newborn baby has their unique feature we will discuss in the next few slides, that could be a problem. So remember, rhinorrhea, which is runny nose, we speak different language. When you talk to your medical team, compare you talk to the parents, the caregiver, it's different language. One called the plain language, it's runny nose. The other medical term is rhinorrhea. We need to know both. You need to know how to talk to your patients and their caregiver. If you tell them rhinorrhea, that's what my students do all the time. Okay? When I ask them to educate me before they talk to the patient, or sometimes I ask them to, I observe them to do the education. They always use the medical term. Okay, that's kind of fun. If I use, sometimes I ask them to present to me, they use some plain language, okay? So, it's not, but you must use some plain language to talk to the caregiver, okay? So, it's called profuse rhinorrhea or runny nose. That's the most common, a lot of secretion. That could clog the airway. It's very dangerous for the newborn baby, for the new baby, for the infant, okay? Some others is because their airway is so narrow, it can cause the difficult breathing. Those difficult breathing, you can see many signs and symptoms. Their nose will flaring, and then their heart will bumping, like you can hear, you can see. And their abdominal will be, you can see the belly breathing. And you can also hear the wheezing. Also, those rhythmic grunting during the breathing. Those means they work so hard on breathing, okay? And also, because of that difficult breathing, and they will have a rapid breathing, which is tachypnea, okay? So those are the most common for RSV in the infants, okay? And they could have, because of those airway clogging, not enough air into the lung, so they may have those cyanosis, means their collagen to and many times it happens, the loss of smell and the taste. Like I said, you need to remember RSV usually causes low-grade fever, usually causes profuse rhinorrhea and tachypnea and difficult breathing. Those are the most common in RSV, okay? So why pediatrics, especially the first year of the life, those infants are high risk? Because their immune is not fully developed. They lack the surfactant. You know what is surfactant? Why is surfactant in your alveoli? Surfactant will make that alveoli open and close. It won't collapse. If you don't have that surfactant, it will collapse. Okay? So, but that makes the newborn, the baby, very easy to collapse because they don't have enough surfactant to support the open and the close, cycle. Okay? And also their airway are more smaller and underdeveloped those cartilage, to support it. So it's very easy to clot. Those mucus will close off that airway easily, okay? Make them difficult and faster breathing. And also they have underdeveloped muscle here, so this also makes it difficult. That's why you see them belly breathing, very common, okay? So those newborn baby also have the periods of apnea. If you have a baby, you probably know, right? So they have you cannot feel any breath for 10 to 15 minutes, seconds. 10 to 15 seconds, they just don't breathe. Called apnea. It is not, and the newborn could have that. It's normal. But those increase the rate for the newborn baby have this all the risk. So this is one of the questions. How long the incubation period? Is 2 to 8 days. Means say today I get exposed to the RSV, your newborn baby gets exposed to the RSV, then may get sick 2 to 8 days later, the signs and symptoms start showing because the virus needs some incubation time to replicate and cause the signs and symptoms, okay? So, and they usually have increased coughing and lower grade fever, tachypnea, and they usually feel very tired, they refuse their feeding. Also, they have those poor breath sound. We'll discuss about the supportive care later. Because they refuse the feeding, that's cause issue, the dehydration issue. So that's some other support interventions we should give to the patient. Okay, so how do we diagnose this? The virus, you don't really require to know exactly that is RSV. It's based on the clinical sign we just discussed. Those clinical presentations. It was like, oh, this is the baby. This baby could be RSV because you don't have any different treatment. All the virus you do the supportive care, right? So it's clinical diagnosis. That's really you do just based on the clinical diagnosis. You don't really need the test to support. However, for those high-risk baby, if you want to know if not exactly RSV, there are rapid antigen tests and the PCR-based testing available. There are also some point of care like the COVID to test the RSV. But because of the sensitivity and specificity, so it may not give you, it may have some false positive, false negative results. So you need to remember, we always based on the clinical presentation to the clinical diagnosis. It does not always require the test. However, the tests are available. Okay, the testing are available. So we need to know sometimes when you're all adults and the children, when you have virus the pneumonia, the treatment should be different. Okay, the pneumonia definitely will need more close monitoring. This is one of the respiratory viral panel. If you will go to rotation soon, you will see it in your patients because we did that in many of our adult patients as well as children. It's a PCR panel. Then you can tell what is the virus. Okay, so you can see a lot of virus panel there. So you will see if that is a virus or bacteria. Or from chest X-ray, the physician may tell you could have both. But if you know that it's viral and they don't have bacterial infection suspected, you can stop the antibiotics, right? You can do just the supportive care, okay? If they are influenza, then you can give the Tamiflu for the treatment, okay? How do we prevent it? So the prevention is actually hygiene. Because it's transmitted or spreaded via the contact of the droplet. So you can tell you actually need to wash the hand, teach the baby and their parents, their caregiver to wash the hand, and don't touch the nose. It's difficult for the infant. What they like to do is snap their fingers, right? So it's very difficult, but you need to make sure to wash your hand, teach the parents to wash their hand, wash the siblings' hand, wash the baby's hand more often. Okay? And then you also want to wash their toys regularly to clean it. Especially sometimes the daycare they will send out to say we have some kids get infected with RSV. You may want to educate the parents to be more cautious and wash their toys and want to cuff their calf and sneezes so that droplets won't spread broadly, and also keep the baby away from the crowds. So I worked for children's before, so they actually the pediatrician doctor educated those premature baby parents. Say, don't feel hesitate. Bless you. Did you cover your sneezing? So, say if you have a premature baby, never hesitate, because your family the relatives may say, we want to visit your new baby, we want to see it. Never hesitate to tell them. We want to, because this is a premature, high-risk newborn baby. Can you come like a few months later when the baby grow up and immune system getting better? You can always tell them. If that is the RSV season, flu season, sometimes they hesitate to refuse, but you don't want to get the baby sick. That's how we should educate parents, okay? So they have those preschool daycare, the siblings, which they get exposed to the crowd. They make sure they wash their hands, maybe change the clothes before they you take them into the house, and attending the daycare centers, those crowded environments, and if they are exposed to the smoke. So those babies are increasing the risk, besides the premature baby, okay, or the pulmonary comorbidities. Is there any vaccine? Now says no, unfortunately. So these are all on developing. I read some references. I was also hesitated why we don't have vaccine. For the infants, it's because it's just not effective. It lasts a very short period of time. So that's why there's no vaccine. Possibly in a few months later or a year, you will see the vaccine given to the pregnancy woman. If they give the vaccine to the pregnancy woman will have some antibody, right? They can do the passive. They can pass those antibodies to the baby, or when they breastfeeding the baby, they will also pass those antibodies to the baby to help to fight the RSV. They are also trying to do there are prevention, we'll discuss that. That's pretty much the only medication we discussed in this lecture. This is not my favorite lecture. I'm a pharmacist. I want to tell you more, discuss with you more medication. Only one medication, then you know every slide regarding that medication is testing point, right? Because we're pharmacists. Okay, so, but there are many labs. They are doing the research on the long-lasting monoclonal antibody. So we don't need to give that very often to the baby. Right now, the only monoclonal antibody need to be given monthly. Okay, so I'll discuss that. But the key points you need to know: there's no vaccine for the infants for RSV. Okay, but this is the medication I mentioned to you. You need to know the brand and generic always, called palivizumab. So this is a monoclonal antibody. How it works is it can bind into the antigen on the surface, and so that make this virus won't bind into the cell and replicate. That's how it prevents the RSV, but only for prophylaxis. Remember, only for prophylaxis, not for treatment. Okay, only for prophylaxis. Once the baby gets infection, should you continue this medication? No. Okay. So this is only prevention of the severe lower respiratory tract diseases for those children who have high risk and during RSV season. Okay. So this is also slides. They help me analyze because I'm telling you, we are pharmacists, so we got pharmacist training. Only medication we're discussing this lecture is this medication. So who should receive this monoclonal antibody? Remember, that's the first year of their life is indicated. So the first year of their life, those premature infants were born at 29, less than 29 weeks gestation. Say if they're born 23 weeks, 24 weeks gestational, okay? Also, if they are less than 1 year, less than 12 months. Does that make sense? So their age, say, I'm telling you, this is the 4-month baby who was born 23 weeks gestational. Right now is their RSV season, November. Should you give this medication for prevention? Yes? No? Yes, right? Because that baby is less than 12 months. It's in the first year of their life. The gestational age is less than 29 weeks, right? Okay, so you need to tell who should get it, okay? That's the question too. Because that's the key. We need to know who should receive this medication. And also those premature baby, if they have chronic lung diseases, if they were born less than 32 weeks of gestational, they should also get it, okay? If anytime they have certain heart diseases, congenital heart defects, they should receive it. But all of those babies should be in their first year of life. Anytime I tell you, this is 3 years old, they were premature baby, but they were born 23 weeks gestational week. But this baby, this toddler already, 3 years old, should we give it? No, why? Because we just discussed that almost all the children already get exposed before the 2 year of the first 2 year, right? No, not applicate. Only the first, only the first year. Okay. So how we dose it is monthly. It's not long acting. They're doing research on that. Long acting probably in the next year or two, maybe 2 to 3 years, you will see another monoclonal antibody given just once and last for a year. Good news. Okay, but this medication only given monthly, so you usually cannot receive more than 5 monthly doses. Okay, maximum dose is 5 doses during that RSV season. Okay, if the baby becoming infected, should we give this monoclonal antibody? Should we stop it? Stop it, because this only for prevention, right? shouldn't give oxygen supplement, okay? Also keep them hydrated. We just said it will make them loss of appetite, they refuse the tube feeding or breastfeeding. What you can do, you want to provide some small, frequent, very small portion so they can slowly tolerate. Don't tell me how I learn. Well, I have 2 kids. You know, when they get sick, you always give them very small, like 5 milliliters of water at once until they get to tolerate it. Because they feel nausea and vomit. You give a big bulk of the meal, then they will vomit out. Then they lost the appetite. They won't eat for another few hours. Okay? And also, if needed, they just continue to refuse all the meals. They just, because of the coughing, the nausea and vomiting, they need some IV fluids. Maybe go to some pediatrician. Maybe some severe cases need IV fluid in the hospital, and close monitor the oxygen as well. Because of a lot of secretion, you want to clean their nose. Can you teach your baby to blow their nose? No, that's so young, right? I have a question there. So I don't want to, you know, but if you don't have the baby, you probably don't know. But if you have baby, you will know. Because those newborn baby, no way you can teach them how to blow the nose. But you can help them. There are some bulk syringes to suck those secretion out and clean the nose, so that clean the airway so they can breathe smoothly better, okay? Also, we want them to get more rest and nap. And treatment, there's one treatment we do give while working for children, the inhaled Respiratory. Are you familiar with this medication? Did you hear about this medication before? What is used to treat? HCV, right? You don't see that very often anymore. But before, like 10 years ago, you could see actually the mainstream treatment for HCV. A lot of side effects for systemic treatment, but this is inhalation. So remember the brand name. What is the brand name? This is one of the question, okay? So some of the, I just give the people the ID review for 2 days. So actually a lot of brand and generic questions they like to give. So when you start the Netflix, the eyes crack, make sure you remember all those bolded brand and generic name, okay? So those are one of the testing points. How do you relieve the symptom? We already talked about that. You want to manage the fever and the pain with over-the-counter fever reducers. Can you use acetaminophen? Yes. Can you use ibuprofen? Can you use aspirin? No. Never aspirin. Okay? We'll talk about the lung disease, you all know. Yeah. It can cause severe signs and symptoms and side effects. So you can choose acetaminophen or ibuprofen. Also, you want to make sure to give them enough fluid in small portion, okay? So keep them hydrated, prevent dehydration. It's applied to all. If the children has any, you want to actually the pediatrician you can call the pediatrician's office and discuss with the doctor about this. So they will give you more information. And so that's all for the RSV. Do you have any questions? If not, we'll go to the lung because the lung has more information there. Any questions? Can you guess what the question looks like? Because I already mentioned that to you, right? Where's the mouse? Oh, there. Okay. So like alert pop up, right? You override it, not override it. We did many investigations for the pharmacists who override them wrongly. You should not override. If they pop up some drug interactions, those are major drug interactions, you should do something. You probably lower the dose, probably stop one medication. You probably provide education for your patient to monitor the side effects. You need to do something for some of the alert. That's why you have alert, right? But you cannot just say override. No. Every time I see those alerts, well, I verify. I don't do a lot of verification. But central pharmacy always route those difficult, whichever those others have some issues they're not comfortable to verify it. They always verify to those specialists. They route to me. So we always verify those orders who are considered difficult. So we actually verify orders, but those difficult orders, which need clinical judgment, which need to do some more investigations. So we didn't know how to override. You cannot just click it, right? So you think about it. You need to know those. What are those common side effects? If you work in the hospital, of course, this is one of really have a lot of drug-induced problem, or even death every year reported. One of the reasons why it has increasing now, one of the reasons is we have many drugs right now. The other is the reporting system getting improved. So that's why we got more report. Do you know which website? It could be your informatics question. Which website you can go to get those information regarding the drug safety? Did you hear about ISMP? It's called ISMP. Don't ask me what's the full name. So we report all the events to the severe events to the ISMP. Then the hospital or the pharmacy receive the report from them, and then we will know what are those high risk possibilities, and so we can know what we can do to prevent those events. Always have some interventions we can do to prevent the event. So this is a complication, pulmonary complication actually is the largest proportion of fatality. Why? It's because lung is your major organ. If your lung failure, it causes cardiac failure, and then further the other organ failure. So it's actually very important. And those certain medications or some patients have specific risk. So in this lecture, I want you to understand what are those common causative agents? What are those high-risk population? Okay, so you need to recognize those. Then you can know how to do for those situations. Like I said, you could change it to alternative treatment because the patient has high risk or previously already had pulmonary toxicity because of drug. Or you could lower the dose, or you could educate your patient to close monitor and report to the provider those signs and symptoms of the toxicity. Does that make sense? So you can understand what to do. If you only remember one thing from this lecture, the website. Why? Why do you know this website? In the future, do you think you can remember all the thousands of medications listed here for you to, let me see if I can link and demonstrate for you. You need to know those resources for you to check. What are those medications? What are the side effects they may have? so many patients, your physician asks you to review and see if you can tell if that patient has any. Why I cannot share the screen? Okay, good. It's actually doing the screen model. Great. Okay. You need to know some resources to help you to check those medications. After this lecture, you will go practice. After your APP rotation, you will go intervention practice. So in the future, more medication come up. More medication maybe have side effects. How can you check it? You need to know some resources. Okay. Lexicon or micromedics could be your major resources for pharmacy. However, there are some unique resources you should know for your practice. This is one of them. Called Drug-Induced Respiratory Diseases website. So those numbers like 5 means it already have 200 cases, over 200 cases reported. For that drug means it's definitely a high risk. Make sense? If you want to know if your medication has side effect there, you just search. You just search and say I want to know nitrofurantoin, okay? That's one of the famous medications. So you see there. Then we'll give you all the signs and symptoms, all the the specific pulmonary diseases this drug induced. And you see many of those still has 5, means pneumonitis. Okay? For this pneumonitis called ILD, it still has 5 over 200. Means this is really have a lot of cases reported for this medication. Do you understand? So in the future, if you will practice, your doctor will ask you how to review those medications and find out those suspected causative agent. That's the best website to go. If I test you this, will you get the correct answer? What is the website? Pneumotox.com. The lexicon, micromedics, lung tox, respiratory tox, pulmonary tox. It's called the pneumotox, okay? Pneumotox.com, okay? So you must remember this. And also, it has a very good app in iPhone or Android phone. You can download it. You will work as a resident in the future, so you can quickly pull it out and get those information. My suggestion is if you will go for a resident, make sure your phone really have a good memory card. You know, a big memory card. I buy a phone which is not new anymore, but I have a 256. I learned because back then, the lexicon already have like 13 gigabytes in my phone, but I need it. But my old phone don't have enough space, and then I keep delete it and reinstall it, and then I buy a new phone with 256 gigabytes. I'll say, I don't need to worry about it, right? So some of those apps you definitely need to keep in your phone so you can pull it quickly in the routes and get those resources, okay? So this is a long picture, so you know your lung. Tell me what this why usually your artery is red, right? Your artery is red color and vein is blue color. And tell me why in the lung the artery is blue and the vein is red.
Oxygenated.
Correct. Because of the oxygen. After the blood flow through your lung, it's actually got oxygen exchange important to understand the diseases. Okay, so then those full oxygen blood will flow to the heart and then pump up to all the tissues and organs. Okay, so this is your lung called parenchyma. That's the basic unit of your respiratory. So those are the unit full of the alveoli, and where it gets the blood, the capillary, and gets the blood changed, oxygen exchange. So the most common drug-induced pneumonitis is actually occur here. Okay, so it causes inflammation and then affect the lung function. And then you also have some called pleural. That's the pleural is a space between your lungs and also the muscle and skeletal tissue. So the space are very commonly maybe get the fluid accumulated called pleural edema. It may be caused because of the heart failure, right? Or the other water retaining problem. But it may be also caused because of the drug-induced, okay? So how this works, it could be because of the direct toxicity your drug gives to the lung tissue. They directly attack those lung tissue and cause the lung tissue, those tissue death. It could also because of some immune system. Those immune system will activate it, very similar to those autoimmune diseases, and then cause the tissue to die because the immune cell attack them. Okay, wrongly. It's supposed to not happen, but it happened. So what are those risk factors? You can imagine. Anytime there's really no predictive model, that sometimes when you come to the, for example, how do you tell your patient liver disease stage? Child abuse score. But there is no score here said I can predict this is most likely drug-induced pulmonary diseases. There's no predictive model. But what you can tell is, oh, this patient is high risk compared to the other patient. So how can you tell if they have multiple drugs? Just like what oh, that's the P4 students. I'm sorry, I get confused. So sometimes the P1 interviews with P4. So I give them ID review. I tell them QT prolongation medication. If your patient has 2 or more combined medication which have the cardiotoxicity, the QT prolongation side effect, which definitely increase the risk. Because they may work in different mechanisms that combined together synergize the side effect. So anytime they have multiple pulmonary toxicity medication, same mechanism, increase the risk. Also, anytime they're really advanced age, nowadays we see more like 90 years old, 103. I recently see a 103 patient. So I follow up that patient every day and to see what the new medication started or what the patient status looks like. Anytime they're at those extreme age, advanced age, they're so vulnerable for all the side effects. Because their organ already kind of at those really work hard. So we need to keep an eye on those advanced age patients for sure. And if anytime they are smoking, especially current smoker increase their risk. And then, of course, past smoker, if they smoke a really long time, that also increases their risk. And existing lung diseases, asthma, COPD, pulmonary artery diseases. Do you have a pulmonary artery hypertension lecture? Yes? Yeah, that's very important. A lot of new medications there. the medication has a REMS program. We work on those very often in our practice. Then you also, if they have renal diseases, because those may cause the medication accumulation and increase the side effects. And also, if some medications like the Drug-Induced, if they have higher accumulation dose, amiodarone, bleomycin, nitrofurantoin, or if they have high maintenance dose, we will discuss that in some future lectures. Oh no, not slides. Anytime they have high dose, usually they are dose dependent. High dose, high accumulated dose, high daily dose for long term. High means maintenance dose. Those all increase the risk. Means they get drug exposure. Okay, and then for those poor performance status, if they have cancer therapy, if they are immunosuppressed, they are more vulnerable for the side effects. Also, why oxygen? Can anyone tell me why oxygen increase the drug-induced pulmonary toxicity? Here mentioned the bleomycin, because it has evidence and the studies show. But many other medications, high oxygen, if that patient needs oxygen treatment, very high oxygen, like long-termly, they bring the oxygen tank all the time with them. That increase their pulmonary toxicity. Do you know why? Because oxygen can generate a free radical. And then those free radicals will attack those lung cells and cause toxicity. Does that make sense? That's why in critical care, if that patient is mechanical ventilated, means we are giving them high concentration of oxygen. Your medical team, the resident, the fellow, they check that patient very often, try to always tapering down the mechanical setting, the ventilation setting. Because you don't want those long-term oxygen treatment, which may generate those free radical, which attack the lung cell and cause the toxicity. Does that make sense? So you need to understand why, and then you will know how to do it. Sometimes students said, I just want to memorize it. No, you cannot memorize. After 3 years, your eyes spread this thick, right? How can you memorize all of them? Now, many general rules you comply and understand. You don't have to memorize. You only need to memorize certain things, and once you understand, those just make sense to you. You have the tree. You connect them together. Okay. So this is just another picture from your pharmacotherapy book, the Hero book. Same philosophy, which I already explained to you. Those advanced age, multiple committed drugs, or the accumulation of the drug exposure, high maintenance daily dose, or they maybe just the genetics sustainability make them more vulnerable for their lung diseases. Those increase their risk. And then if they receive oxygen, remember, it will generate those free radicals, so it will increase the toxicity. Same what we just discussed before. There are some types, basically definitely more than that, but these are the common types, which may cause the drug-induced. If you want to ask me, I just show you the nitrofurantoin, right? How many type of lung-induced toxicity do you see? I didn't count, but definitely more than 20, right? Because they, generally speaking, the drug-induced pulmonary toxicity could be any of the pulmonary tissue. But the most common one is the bronchitis and also the pneumonitis. That's the most common one. And it may cause pulmonary edema, may cause pulmonary pleural effusion, which we just discussed, between this muscle and the bone structure and your lung, there is a space. It causes the water retaining there. And then it could cause pulmonary artery hypertension. Those are the most common type. What are the signs and symptoms? Well, anytime your patient has lung diseases, what are the signs and symptoms? Tell me. You cannot tell from the signs and symptoms. They are always non-specific. What are they? Do they have coughing? Yes? Yes. Right? Could be dry cough or wet cough. Could have blood in the sputum. They may feel chest pain. That's why if your patient comes to the emergency department, they complain of chest pain. You have to rule out many of doing the differential diagnosis. I'm not a physician. I don't do diagnosis. I don't do diagnosis too. But I understand diagnosis. I read all of their imaging results, and I read the notes, and I understand the diagnosis before I start to work up my patients. So we need to understand the diagnosis. We don't diagnose the patient. So you need to know why they diagnose that. So if your patient has wheezing, short of breath, or chest pain, that's the most common signs and symptoms indicate they may have pulmonary diseases. All of those are non-specific. We don't know if that is really drug-induced pulmonary diseases. But you are like, how can we diagnose this? Remember this term, we call it diagnosis of exclusion. Means what? Means we cannot definitively diagnose this is the drug-caused induced pulmonary diseases, but because we work all the labs, imaging, all the other workup, and exclude all the other causes. We exclude the PE, we exclude the heart failure, we exclude all the other possible, we excluded the infection. And now we are suspecting this is because of the drug. They just started 2 weeks ago. And now patient developed the signs and symptoms, right? Then we said this is possible the causes. That is called the diagnosis of exclusion. Means you don't know any other causes that may cause this patient have this lung diseases. No malignancy, not cancer, not PE, not heart failure, not any of the other diseases, not infection. Then you were like, oh, because we just started amiodarone. So, and also maybe this patient have been on amiodarone for half a year, and daily dose over 400 milligrams. So we suspect that is the drug-induced pulmonary diseases. Do you understand this concept? If I give you this question, do you know how to understand? How to answer it? It's called a diagnosis of exclusion. Means you exclude it, you rule out all the other causes. Then you said this possible because of the drug. Okay? So well, it has a wide range, not because your amiodarone has been started for 1 year, your patient tolerated. You say this is not amiodarone caused the pulmonary toxicity. No. It could because like a week ago you started this medication, right? And then the side effects start showing the toxicity in the lung. It could be accumulation dose because your patient has been on the amiodarone for a year. The accumulation dose caused the toxicity in the lung. It has really a wide range of the time. And also you need to rule out all the other alternative etiologies, okay? Also, another maybe make you more sure about that medication cost is if you stop those medications, then the side effects start improving. Your patient lung function starts improving. That's how we do it. Do you re-challenge? No. You say, oh, I stopped this aspirin, and then the patient's lung function starts to improve. Okay? Then I was like, not aspirin, actually we can do some desensitization. We'll discuss that in the future. Say, your patient has nitrofuran point, right? So their lung function getting declined, and then you stop the nitrofuran point. You don't do rechallenge. Means, maybe give the nitrofuran point and see patient lung have toxicity. No, that's not applied to the drug-induced lung diseases, okay? Because that's actually increase the risk. You don't do it. But there is one exception is aspirin. We'll talk about that in a few slides when we discuss that. So these are some samples for the imaging. A physician actually taught me before how to read those, but honestly, you don't need to read it, but just show you what the image looks like. Usually, you can go to the imaging notes. The physician, whoever, will give the detailed explanation for that imaging and tell you what happened. Okay, that's what I usually do. Okay, so this is another lab test. What we commonly do for the lung-related diseases, it's called the BAL, called BAL. It's the abbreviation. So this test actually will call the bronchial navigation. So it's actually collect those deep bronchial fluid, and then analyze. How can you tell? If you see any malignancy cells there, that means your patient may have malignancy. If you see any bacteria, send to the lab, they will do the analysis. If you see bacteria there could be infection. But generally speaking, when give us, if you see the lymphocytes greater than 15%, or if you see the eosinophil cells greater than 1%, that means it's possible drug-induced pulmonary toxicity. Okay? There are many other findings basically help you to rule out the other causes. All the purpose is a diagnosis of exclusion. So it could rule out the infection, the other pre-existing lung diseases, or any of the other cardiopulmonary diseases. And any other lab test to rule out the other causes. And you can also have a pulmonary lung testing that can see the obstructive and constriction of the bronchospasm, bronchitis, and also the biopsy can rule out some malignancy or confirming organizing pneumonia. We don't recommend to routinely doing the biopsy. Why? Is it an invasive procedure? No says yes. So if you already have some exclude the other diseases, you don't have to do the biopsy. It's not routinely done. But if some cases, maybe you need to do it to confirm some type of disease. So I give you some examples. Let me show you what's the food. This is kind of more like the food list, but you need to remember it. How says no? I cannot remember it. Why I didn't remember this? And occupy a lot of spaces in my brain. No. Yeah. You can use this to check, right? So you don't really need to know it, but some of the common medications you should always remember. What are those pulmonary lung diseases? When you start studying your X prep, you should always pay attention to those, mostly like those bogus drugs. You didn't know those common side effects. But in this lecture, we are focusing on some of the medications which are commonly cause the pulmonary toxicity, and we should remember them when we see those, okay? One is called aspirin exacerbated respiratory diseases called AERD. A-E-R-D. So this is actually mainly cause the mucosal swelling and also the sinusitis. It mainly causes the nasal polyps and then obstruction of the airway. Because of this, that will exacerbate, may exacerbate asthma, and because of long-term using may cause asthma. So this is it causes more like difficulty breathing, wheezing, and coughing, and bronchospasm. So this is quite usually could appear anytime for children or adults, especially the older people. They may on this aspirin 81 milligram dosing for long term. That may cause the issue. Okay, so we usually most commonly occur when patient has viral infection. Okay, so those ongoing could cause usually always have the asthma with the other signs and symptoms, and the severity and the progression is actually varies, really different. So the mechanism actually make me really like this is unusual as well. I know this medication has a side effect, but honestly I don't know how it. But recently, not that close, but there are some big scientists to figure out what's the possible reason. You know, aspirin is COX-1, COX-2 inhibitor, right? Once you inhibit the COX-1 specifically, okay, it's usually inhibit the prostaglandin, which is the cause of inflammation. Does that make sense? Right? That's why aspirin is one type of NSAID. Are you falling asleep? No? Yes? Or like just get very tired when you look at this. I understand. Scientists get excited on this type of figures. Sometimes you may get wow, so complicated. Well, the key point is if you inhibit the COX-1 using low-dose aspirin, and then it activated the pro-inflammation pathway, which is nucleotide involved. That's the key. Okay? So, do you know what is nucleotide? Can you tell me some nucleotide inhibitor? You already have the pulmonary lectures before. Montelukast. Yeah. And what is it? Xylitol? Yes. So those are nucleotide inhibitors. One is nucleotide inhibitor for asthma. Because the nucleotide actually involved into the pro-inflammation, make the airway inflammation pathway. But low-dose aspirin, although it inhibits the COX-1, meanwhile, it activated the nucleotide pathway and caused the issue. That's why most of the people actually have asthma signs and symptoms. Does it make sense to you right now? Okay? Don't get wow, this is complicated. This is not complicated. This is just to explain to you how the nucleotide play a role in the asthma and how you can treat your aspirin exacerbated respiratory diseases using nucleotide inhibitor. Does that make sense?
Yes.
Okay. Don't think you, sometimes when you understand those pathways, then you don't need to memorize it. Probably because my memorizing is not that as good as some of you, so I don't like to memorize the things. I like to understand it. So diagnosis again is rule out all the other possible causes, use the CT, but this one it may use in the re-challenge to see if the patients do have signs and symptoms after you increasing the low dose to the high dose of aspirin. Then you will know if that is a possible aspirin cost. Okay? This is pretty much the very few exceptions you may use for re-challenging. Otherwise, you don't re-challenge. It's very rare in the pulmonary toxicity. Can you remember this word? This is one of the questions. Okay? Re-challenging is very uncommon. You don't re-challenge. You stop the causative agents. Okay? How do you treat it? Can you tell me how do you treat it? If you suspect that kind of medication can cause pulmonary toxicity, what's the number one thing you do for all the medication? You stop it. like this medication. Once daily dosing and cheap, right? So those are like, after years, you will see some medication has more market than the others. There are some reasons behind, okay? So we use Nucleotide because of the unique pathway I explained to you, and some because it also causes the nasal polyps, which block the airway. So some surgical intervention may be given for those patients. Do you understand what I'm talking about? Some of my students, when they come to rotation, I have to explain to them, your medical intervention is not the only one. Many of the patients come to our clinical, the surgical intervention are important. So how do we know? We don't do the surgical, we read the notes and read how the surgical plan, what are the surgical results, and to understand how do we treat them, okay? So we do aspirin desensitization. We just discussed, we stop the medication, we probably go alternative treatment, but some of the diseases, we just have no option. Can you name one of the diseases? We have to use aspirin for them to treat. Don't remember? Do you know the stent? Called the dual antiplatelet treatment. What are the dual antiplatelet treatments for the stent? Aspirin and the tablets are the most common one, right? So you use aspirin plus tablets, right? So aspirin is required to prevent the stent clot. So for those patients, you probably have to do the desensitization to sleep. So this is the desensitization. It's indicated for those patients if they frequently grow the nasal polyps and require aspirin or NSAID for the cardiovascular diseases. For sometimes also because of the COX-1 inhibitor issue. So you actually cannot use aspirin and ibuprofen, naproxen, or NSAID because all of them inhibit the COX-1. So some of the rheumatoid arthritis patients also need NSAID for treatment, right? So you have to do the desensitization for those indications. You can start 2 to 4 weeks after the surgical debulking, remove the polyps, and you can also actually start with the half tablet of the 81 milligram aspirin, and then go titrate in 2 to 3 days, and then go all the way to 325 or 650 daily dose, so that you can continue that dose. What medication you can use for those patients? Because all the NSAIDs except COX-2 specific inhibitor. Name one. That is COX-2 specific. So that one can be used for this situation. That's the alternative drug. But you don't use that for the stent. Did they tell you that? Because aspirin has antiplatelet issue. Antiplatelet property, but celecoxib don't. Okay? So amiodarone is so important drug. It's another drug I almost always review this drug with my AP students. So that's why sometimes when they come, to the lab, I saw a question. I said, I told you because this is so important medication. We love this medication. We also are very cautious for this medication because of the many side effects. You see, I highlighted there, I underlined there. That means those are the testing points. Okay. So this is the iodized. Because of that, which organ you think it will affect? It's iodized. Which organ? Thyroid. The number one side effect come to your mind should be thyroid. Yes, it's affect the thyroid function, could go upper or lower, hyper or hypothyroidism. It's for the patient, then they could cause pulmonary fibrosis. And what actually makes this medication so unique? Do you know how long this medication, the half-life? How long? Guess. No? No number? Tell me some number. I want to make sure you all wake up. About 2 months. What concerns you? Why this is so important? Do you know I'm training your clinical skill? I'm actually training your clinical skill. Once you're aware of pulmonary toxicity, you stop it. So your medication half-life is 2 months. It's probably lasts all the way to a year in your blood. It's continue to cause the pulmonary toxicity. Right? That's the issue. That's why most of the time for this type of patient during the steroid treatment, even you stop the medication, always number one stop the medication, then you may need the steroid treatment because it lasts so long. The half-life is almost 2 months. Okay? Understand? Now you know why your pharmacokinetics knowledge is so important. I asked a stupid question. I don't think there's always no stupid question. But I feel like that moment, I was like, my presenter feel I was stupid. Why? Because that was some relevant time. Now, your specialist treat you as a colleague. They won't make you that feeling. Never, we are like colleagues, we respect, we ask each other the question all the time. Nobody really feel like, but that moment, my presenter really make me feel I was stupid. Because I was like, we had a pharmacokinetics topic discussion for pediatrics patients. But I asked, how do we dose the pediatrics patient? We dose based on the milligram per kilogram. No matter their neonates or their teenager, okay? But their pharmacokinetics varies so much because when they grow up, their renal function, their all the other metabolism, liver metabolism, all changes. But you dose all about milligram per kilogram dose, right? I asked my preceptor, what matters about the pharmacokinetics? You discussed the whole hour with me. Do we ever use the pharmacokinetics for the patient? We always dose the milligram per kilogram. Am I right? I was right. That moment she was like, she looked at me and was like, why do you ask this stupid question? Like, you think pharmacokinetics is not useful? At that moment I do think, why do we know this? But this is another, I talk with you in infectious diseases. While my career lasts at this moment, I feel pharmacokinetics so important. For me, for some clinical judgment, for me to understand what do we do for those patients. Do you think in this specific cases, pharmacokinetics is very important? If you don't, you understand amiodarone has all the other drugs like anticoagulant, Eliquis, half-life is about 12 hours. You stop the medication 2 to 3 days, the drug disappears from your blood. But this medication, the drug disappears from your blood probably lasts almost a year, right? It continues to damage the lung. So this is so important. That's how you apply pharmacokinetics, okay? So I also make them very vulnerable to the photosensitivity. So they are that's the key points for you to educate the patient to prevent the sun exposure.
Excuse me. Will a discoloration be on the dark skins to make it visible?
I'm sorry, what's the question?
Will you be able to see the discoloration on the dark skins?
Probably not. Yeah, you won't be able to see. So that's a great question. I think it's very important to educate the patient, specifically the dark colored skin, because they may not see it, and this is actually can cause issues there. So okay, so that's very unique side effects. You probably want to see the side effect of any of the other drug. And then also we talk about the thyroid dysfunction could go hyperthyroidism or hypothyroidism because it has iodine in the medication. The iodine actually affects the thyroid. It can cause us corneal disposition. And at that moment, your patient cannot see. It has to go surgical to fix it. And then it can cause abnormal liver function. I have a patient who has this liver, we monitor and we actually we discontinue amiodarone for the thyroid dysfunction patient before. It can also cause bone marrow suppression. There's a lot of side effects. Okay. Did you see the can it cause the blood glucose issue? No. Okay. At least not a big portion. Okay. If I give you this question, do you know how to answer it? Okay. That's one of the questions. It also has major drug interaction. This is one of the unique medication, which is pretty strong inhibitor. What makes this medication unique is this medication is a broad CYP450 inhibitor, which means it actually has a lot of drug interactions. You specifically keep an eye on it. For example, if amiodarone and digoxin given together to the patient, the digoxin is reduced to 50%. It's a major drug interaction. It also inhibits the P-glycoprotein. So remember this, all the antibody part in the pathogenesis is always, for amiodarone, let's talk about it, the cumulative. And they have a high cumulative dose, which actually cause more toxicity. Usually after several months or several years, the accumulation dose accumulates the toxicity in the lung. If their daily dose greater than 400 milligrams per day, remember that dose. Okay? Maintenance dose. What do I mean maintenance dose? Maintenance dose means chronically taking. Okay? It's not like nitrofurantoin for the UTI treatment for 5 days, 5 days, right? So those short-term treatments usually won't cause the issue. We don't say that. We don't make that term maintenance for those doses. Maintenance means your patient chronically taking. Okay? So if chronically maintenance daily dose over 400 milligrams increase the side effect as well. So anytime they have extreme age, existing lung diseases, those all increase the risk. The evaluation, I didn't see anything unique here. It's all because you always exclude diagnosis. You we call it a diagnosis of exclusion. Move out all the positive diseases. Differential diagnosis. How do we treat it? Always stop the positive agents first. Then, for those asymptomatic patients, you probably can observe a little bit, but you still need to keep observing because of the long half-life, right? Just like I mentioned. You probably need a treatment soon. But any of the symptom patient, you need to treat them with prednisone steroid, 1 to 2 milligrams per kg per day, with the tapering after 4 to 6 weeks if the symptom improved. And then you should make sure to take slowly, because even you stop the medication, this symptom may still come back because of the long half-life. So you should, over 2 to 6 months over that tapering period. You may need last for a year. Okay? For those initial pulse methylprednisolone, you can use 1 gram dose daily for 3 days. Methylprednisolone, you probably think that's a very high dose. Yes, it is. The first time I saw this dose was in my practice at Children's. This medication usually using for 3 days, 1 gram daily for 3 days to treat those like acute inflammation. So if you see this in the future in your own practice, when you verify this medication, you go to lexicon and see the indication. If the indication applies, don't feel surprised. Yeah, this could be the dose they should be given. But don't think, wow, 1,000 milligrams a day. Okay, that's not a unique dose. Okay, because of this, this said 45 days. Sometimes they said 56 days. It's usually about 2 months. It varies. Actually, different people maybe have different pharmacokinetics, metabolize rate. So it could last really long. So need to continue treat if they have symptoms. You never resume the amiodarone for those patients. It's very high rate, they will recurrent and then cause further fibrosis. Once the patient has lung fibrosis, just like the liver fibrosis, the dead tissue won't regenerate. They're dead. Then the function declines. So you may want to use alternative medication. I just mentioned, we love this medication, we hate this medication. We love this medication because this medication actually stays the most effective medication to treat the liver. But because of so many side effects, it causes the intolerance issue. Then we start the patient with some other medication. Triclosan is one of them, and we may use dronedarone, but none of them as effective as this medication. But they do have some alternative medication to use. Okay, just keep in mind. We'll change it to other medications. Immune checkpoint inhibitor. Honestly, I'm not oncology specialized. I'm ID, but this is medication. Like all of us, we definitely need to know because this is one of the medication which advanced in the past years. It's so popular and so hot field, and it advanced the lung cancer treatment in the past years. And so, but this medication is called immune. It's actually work on the immune system. So, do you have any idea about those T cell CD4, CD8, CD3? You know something, right? CD4, HIV, right? Then they affect the T cell. And HIV virus causes the T cell die. And this cancer cell, in the microenvironment, those cancer cells has what's called a PD-1, PD-L1, and also have this called B7. Those can bind into your T cell, the membrane, and inhibit your T cell. So your T cell won't get activated and replicate. What does that mean? That means decline the immune system, right? Otherwise, if your T cell can recognize those tumor cells, they will kill it. But your tumor cell was like, no, I will do opposite or inhibit you. So that's why this is called anti-PD-1 or anti-Syncytial A4 or anti-PD-L1. Those become the drug, the mechanism, how they drug to treat the tumor. This is really popularly used, but these are some of the medications. You definitely probably see some of those in your oncology lecture. So those are monoclonal antibodies used to treat the tumor, but the common side effect, very high ratio, your patient developed the pulmonary toxicity. It's all because the very high ratio is because it's work on the checkpoint inhibitor may attack the lung and many other tissues actually. So if the lung toxicity, you primarily treated with steroids. Okay. Similar treatment to region number 4, methylprednisolone high dose for 3 days. For the pulse dose, and then you using the prednisone 1 to 2 milligrams kg per day dose, and then tapering down. There are many other steroid-resistant treatments. You don't have to know, but there are some options for treat. So methotrexate, you see I highlighted this because I really want you to know everything about I'm talking about in this lecture. There are many questions here. Why methotrexate? This is one of the medications we mandatory to provide education to all of our patients starting this medication in the hospital. This medication is also another medication very commonly used for chemotherapy, different dose, as well as the rheumatoid arthritis. What do we call this medication? Called drug, traditional drug, right? We will see that in the next slides. Why I see so many confusion things? You should have this topic before, right? No? Yes? Cannot remember. Okay, so methotrexate is another medication they like to test it because so many medication side effects and also drug interactions. So we will refresh some of the knowledge because it can also can cause pulmonary toxicity, but we want to refresh some of the knowledge for your test, for your knowledge purpose. This is another medication they like to test it. From mechanism of action to indication to side effect to monitor. Okay? So methotrexate is a folate anti-metabolite which can be used to treat cancer and also to treat the autoimmune diseases like rheumatoid arthritis. Still stay the mainstream treatment. So this actually may cause direct toxicity to the lung and may cause hypersensitivity. And it's really high rate according to current literature, depending on the dose, from 1 to 7%, can cause the pulmonary toxicity. And the onset, it could very short days or years. And for those patients, for rheumatoid arthritis, about 1% is overall pretty low dose because for the rheumatoid arthritis treatment, it's overall low dose. But for chemo treatment, it's high dose. It's usually given IV. But folic acid. Do you know what folic acid is used for? It's always combined with methotrexate. Why? Because methotrexate is an anti-folate pathway. What folate can do? If you knock off the folate.
Iron deficiency. Anemia.
It can cause anemia, yes. What else? It can cause the GI side effects. All of your GI, from your mouth to your stomach, to the colon, the mucus, called the mucositis. Okay? And severe mucositis, your patient cannot even eat. Have so much. So you want to give the folic acid to relieve that GI and the bone marrow suppression side effects. However, the folic acid cannot inhibit the toxicity in the lung. Remember that, okay? Folic acid is commonly combined to reduce the side effects like mucositis, or is always combined with methotrexate treatment to reduce the GI side effects like mucositis and also reduce the hematology like just said can cause anemia. All of those folic acid supplements can help those side effects, but not pulmonary toxicity. Make sense? So this is, I got it from the expert. I want to refresh this knowledge for you. So this is called a traditional disease-modifying anti-rheumatic drug called DMARDs. Okay? DMARDs. Remember this term. This is definitely, I will have a question said everything about methotrexate. Tell me which of them are correct. Okay? Select all that apply question, I think. No remember detail. But anyway, so this medication can indicate it for rheumatoid arthritis treatment, chemo treatment. For rheumatoid arthritis treatment, we give weekly dose. Okay? Not daily dose, never daily dose. Give weekly dose, most commonly. And then it can cause hepatotoxicity, myelosuppression, and it can cause mucositis, and it's contraindicated for pregnancy women. So you monitor the CBC, LFTs, chest X-ray because the pulmonary toxicity, right? And also the hepatotoxicity. Many of the other toxicity you remember for this medication. Can you remember that? And also you need to know folate can relieve, always combine for the treatment to relieve the hematological, GI, and hepatic side effect, but not pulmonary toxicity. Okay? So also has many drug interactions. What you need to remember, this is the acidic drug. Methotrexate. Methotrexate. This is the end. What's that called? Suffix, right? That means this is the acid. So it has drug interaction with the other acid, like NSAID, aspirin, because they will compete the renal secretion, so that will cause both medication concentration go up. If the chemo treatment, if patient has methotrexate toxicity, we will use the bicarb to relieve the toxic, because this is the acid, and it has a lot of many drug interactions. Okay. Other drug, nitrofurantoin is another famous drug. We used to treat the UTI short term for 5 days. Do you think that will cause issue? No. What will cause the issue? For those women who have 3 or more UTI in a year, you give them the prophylaxis. The long-term use of the nitrofurantoin causes the issue. It can cause pulmonary fibrosis. What you can do? You educate the patient to monitor the side effect. Make them aware. If they're long-term use, you probably need to monitor the lung function. You probably need to give them the chest X-ray a year. You need to set up the regular appointment with them to make sure they follow up with you for those side effects. Does it make sense? Okay. So if patient has the side effect, you need to make sure to discontinue this medication and initiate prednisone. For those patients who have symptoms, okay? Usually chronic form is not short-term 5-day treatment cause this fibrosis, okay? And then bleomycin is another chemo medication that can cause the side effect in pulmonary. Is always it's a very high rate. Up to almost half of the patient has this pulmonary toxicity. What do we do for this type of medication? We monitor their lifetime dose. Make sure do not exceed 400 IU per meter square. Their lifetime dose, monitor, not over that. That's accumulation dose cause the issue, okay? You remember that? And also, if for those patients need a regular, because so high, almost half of the patients have this lung toxicity. Besides monitor the life dose, make sure do not over that accumulation dose. You can give them the regular check monitor using this called DLCO. Can you remember this? This is another question there. Okay? Use DLCO to monitor bleomycin dose. Because we definitely need to know that. Maybe a regular monitor. Okay? And if anytime they have pulmonary toxicity, nowadays the good thing is there are many other options to, for example, the other target drug. Okay? So, is there anyone? There's a comment after this one. Oh, no wonder. Many of you study hard. Okay, this is just a case. I won't go through this with you because this case actually I adopted from an article that presented the case. So what the cases help you to know how we usually work up the patient. Okay, so you just come here and also I have the reference. Tell you what this case come from. You can read the original article. This is just for your interest. Okay. So I hope you know what I included in the question. Dorothy, I